Hello and welcome to today's Better Care Playbook webinar made possible through the support of the 7 Foundation Collaborative. Today we are discussing addressing the complex needs of older adults through strong community-based organization and health plan partnerships. My name is Diana Crumley and I am a Senior Program Officer at the Center for Healthcare Strategies. Next slide. Before we get started, I'd like to quickly go over a few logistics. To eliminate background noise, audio lines are muted during today's event. However, we do want to hear from you. There will be a moderated question and answer session following today's presentations. You may submit a question online anytime by clicking that Q&A icon located at the bottom of your screen. Today's event will be recorded and shared publicly on bettercareplaybook.org. So yes, you will be able to see the slides after this meeting that will be posted online. Next slide. Next slide. All right, so today I am so excited for our agenda today. I know that this is of intense interest to our audience. A lot of folks signed up for this webinar. Welcome. Essentially what we're doing today is talking about the why and how of CBO health plan partnerships, talking about that value case and contracting considerations. This is new work. We're going to be doing a deep dive specifically on CBO health plan partnerships for older adults with complex needs. But I will note that some of the resources discussed today will be broadly applicable to a broad range of activities. And then we will have sort of a real world example of what's happening in Ohio. So very happy to do that. And of course, we want to hear from you again. So we will have that moderated Q&A. As questions come to you, please drop them in that question and answer box located below. All right. For those of you who may not be familiar, the Playbook is an online resource center for evidence-based and promising practices to improve care for people with complex health and social needs. Every month, the Playbook summarizes new journal articles, evaluations, and implementation tools. The Playbook also develops resources like this webinar designed to help translate evidence and research into practice. And you can explore that at the Playbook at bettercareplaybook.org. Next slide. The Playbook is coordinated by the Center for Healthcare Strategies through support from 7 leading national healthcare foundations: Arnold Ventures, the Commonwealth Fund, the John A. Hartford Foundation, the Milbank Memorial Fund, Peterson Center on Healthcare, the Robert Wood Johnson Foundation, and the SCAN Foundation. Thank you to our funders. So I said that we would be discussing the why and how of CBO health plan partnerships. And you may be wondering why now, or perhaps you know exactly why now. Why is this top of mind for so many? And I think there are 3 trends to note here. First is screening. More healthcare organizations are screening for social needs in response to shifting norms and new federal and state requirements. So you might see new measures from CMS, from NCQA, and increasing accountability for doing more screening of social needs. You might also see more healthcare organizations looking for ways to promote health equity explicitly. And these partnerships with community health workers and trusted community-based organizations will be especially important to increase access to culturally congruent care. You will also see that managed care organizations' health plans are increasingly actually offering services that address health-related social needs. For older adults, this might look like home delivered meals, home modifications. You might see these traditionally in home and community-based service programs, but recently there's been a lot of increasing access to these services across the board beyond traditional eligibility criteria for those home and community-based services. and a very specific look at transitions of care. So what happens when a individual transitions from a nursing facility, from inpatient hospitalization, from assisted living facility. So with that, you may hear very wonky terms. In Medicare Advantage, you may hear the term supplemental benefits. Some of those have been used to address health-related social needs. In Medicaid, which is where I typically work, you might hear reference to value-added services, in lieu of services, and benefits under Section 1115 demonstrations. And just for awareness, recently the Centers for Medicare and Medicaid Services announced a demonstration opportunity with some options on how to expand access to benefits that explicitly refer to those health-related social needs. Things like those home delivered meals, nutrition supports, food prescriptions, housing supports. So very excited about this new era, but of course, now we have to talk about, how do we get this work done? How do we stand up these partnerships? And with that, I will turn it to our lovely presenters, and you will see their beautiful faces here. Lark Ritchie of the Association of Area Agencies on Aging, and Marisa Scala-Foley, Director of the Aging and Disability Business Institute at USA Aging. They are both members of the Partnership to Align Social Care, and so you will hear references to those resources as well as new resources from the Aging and Disability Business Institute. And we are also joined by Shantanu Agrawal of Elevance Health, and Susan Rawlings Molina of Ground Game Health. And those individuals will also be providing that Ohio context. With that, I will turn it to Lark and Marisa.
Thank you so much, Diana, and thank you all for being here. I am happy to be here with Marisa, too, from the Aging and Disability Business Institute. We will be flowing back and forth as there is a lot of connection and synergy between the partnership and the Business Institute. The Partnership for Social Care was started in early 2020. It was convened with stakeholders from multiple health and social care sectors. And it is continuously adding more stakeholders from community-based organizations, health plans, and systems, and the public sectors. The goal of the partnership is both identifying the essential elements and also co-designing sustainable, equitable, and aligned healthcare and health and social care ecosystems. These ecosystems should prioritize shared governance with communities. Partnership stakeholders envision a sustainable, resourced, and community-centered social care delivery system. It should be inclusive of all populations and empowered by shared governance and financing with multi-stakeholder accountability and include federal, state, and local levers. As part of this work, the partnership has developed and is disseminating numerous resources for multi-sector stakeholders. There are links to many resources in a forthcoming slide, and there'll probably be some dropped in the chat. And there are many resources that are still under development. These work groups are producing resources to help in three ways. First, streamline contracting by leveraging existing community-based resources to provide tools for healthcare payers to identify and pursue contracts with CBOs and community care hubs. Next is to promote the community care hubs by developing expectations of the community care hub functions and capacities, and also enable emerging community care hubs to identify strengths and gaps in capacity. And finally, to facilitate expanded social care billing by building on existing leading practices to expand more opportunities for CBOs and community care hubs to efficiently code and bill for social care, labor, and services. Marisa, I'm turning it over to you to talk about the Aging and Disability Business Institute.
All right. Thank you so much, Lark. It is a pleasure to be here with you all today, to be co-presenting not only with our colleague and friend, Lark Ritchie, but also with the rest of this wonderful panel. We are grateful to the Better Care Playbook for the invitation to be part of this exciting session. Next slide, please. So a little bit about us. The Aging and Disability Business Institute is part of US Aging, which is the membership association for the more than 600 area agencies on aging around the country. We also advocate for Title VI Native American aging programs. And the mission of the Aging and Disability Business Institute at US Aging is really to successfully build and strengthen partnerships between area agencies on aging, community-based organizations, and networks of community-based organizations, including the community care hubs that Lark was just talking about, and the healthcare system, so that older adults and people with disabilities get the services and supports that they need that can allow them to live in their homes and communities for as long as possible. And you see here our URL. We have a host of resources available on our website that we hope you will take advantage of, that are all designed to build this capacity within community-based organizations to be good business partners with the healthcare sector. Next slide. So the way we do our work, we do training and technical assistance to, as I mentioned, area agencies on aging, community-based organizations, community care hubs, networks of community-based organizations. We also have a host of resources, as I mentioned, available on our website, from success stories to readiness tools to assessments that can be used to build this capacity within the community-based organizations and networks of CBOs. We do information gathering through periodic requests for information surveys to gauge the extent to which community-based organizations are in fact contracting with the healthcare sector, and I'll share a little bit about that in a minute. We also have a consulting services program for larger scale projects, also designed around capacity building. And then finally, we provide thought leadership at the national level about the value that community-based organizations and networks of CBOs can bring to integrated care arrangements, to the healthcare sector generally, to promote this alignment between healthcare and the social care sector. Next slide. So I promised you a little bit of data from the information gathering that we do. As I mentioned, we do periodic requests for information surveys to look at how community-based organizations are contracting with healthcare organizations. We have done 4 of those so far in 2017, 2018, 2020, and 2021. And I'm going to share a little bit of the trend data that we've seen in terms of some of this work. The main question that really drives our survey is whether or not community-based organizations are contracting with the healthcare sector. And the good news is that we've seen growth. Since the start of when we started doing these surveys in 2017, we have seen growth in terms of contracting. In 2017, about 38% of the CBOs who responded to our survey indicated that they had 1 or more contracts with healthcare entities. By 2021, that was up to 44%. And the statistic that we got out of our 2021 survey that is my personal favorite is that 90% of contracting community-based organizations reported that they had not only gotten contracts, but that they had had a current contract renewed by their healthcare partner. So not only are CBOs attaining more contracts, but they're also keeping those contracts over the longer term. Next slide, please. The other piece of data that I wanted to share with you for the purposes of the conversation that we're having today about community care hubs and networks of community-based organizations is that we've also seen pretty tremendous growth in terms of CBOs contracting through networks of community-based organizations. In 2017, when we first started doing the survey, 20% of the CBOs who had contracts indicated that they were contracting as part of a network of CBOs. By 2021, that had doubled to 40% of contracting CBOs. Next slide, please. All right, and with that, I will turn things over to Lark to talk a little bit more about their experience in Ohio, and also to share some information about some exciting resources that we at the Aging and Disability Business Institute have been working on with the partnership to align social care.
Thank you, Marisa. I am going to talk about the partnership for aligning social care, but for context on community-based organization contracting with healthcare, I wanted to provide some examples from Ohio's area agencies on aging. So 10 years ago, almost, Ohio embarked on a financial alignment demonstration. And this demonstration involved 5 health plans and 7 regional demonstration areas, which aligned with 7 area agency on aging regions. And the health plans contracted with the area agencies to do, at a minimum, waiver service coordination for people over the age of 60. This allowed the health plans to take advantage of the decades of AAA's experiences in fee-for-service waiver case management. In fact, some health plans broadened the scope of the AAA's contracts to assist plans in more populations and responsibilities. At around the same time, 7 of the 12 AAA's became part of, there were 8 plans 8 AAA's that worked with one plan in administering case management for a fee-for-service NIF waiver. So the result is that all 12 area agencies on aging, rural and urban, have experience contracting with health plans for many years. In addition to these things, there are several models that have grown up working with community care networks to provide transitional care services in Medicare and Medicaid plans for special populations as they're identified by health plans. And the other thing is that in 2012, the AAA's formed, and they all own, a limited liability company called Direction Home. And one of the things we're going to talk about later today is that Direction Home contracts with Ground Game Health to provide services for Anthem. And you're going to hear more about that soon. So next slide, please. One of the things that I want to talk about is how healthcare entities are increasingly recognizing the importance of addressing health-related social needs. And, you know, Diana really covered a lot of this, and she pointed out the reasons why. But historically, I think health plans they've had concerns about contracting with CBOs due to differences in organizational culture or operational infrastructure, geographic coverage, or maybe financing. So many CBOs have developed new capacities to partner effectively with healthcare payers and providers, either individually or with, as Marisa said, the community care hubs. In collaboration with the Business Institute, the partnership is developing a suite of resources that's aimed at helping to make contracting processes easier. The first of these resources, Making the Case, offers a deep dive into the value case of creating these partnerships with CBOs and healthcare networks. And it offers specific examples to highlight individually the value proposition that exists. So the 5 specific areas of focus in this particular resource include: first, it offers the expertise and infrastructure to be powerful innovation partners with health plans. So CBOs can really help provide the social care delivery. Second, they can foster a local presence and engender trust with members that can strengthen health plans' reputation and enhance their market share. There is potential value for CBOs to produce a significant return on investment for health plans by driving down healthcare costs and meeting accreditors and evaluators' measures by linking members to available community care, social care. CBOs can provide health plans greater efficiency and coverage in social care contracts, particularly when working with community care hubs. So by partnering with CBOs, health plans can often secure a competitive advantage. Next slide, please. These are some of the upcoming resources that the partnership plans to release this summer and fall, including the suite of contracting work group resources that we're starting to discuss today. Under contract with the Business Institute, the Camden Coalition is assisting the contracting work group of the partnership in writing a 4-part series, which is fully vetted by the entire partnership planning group. The first, on value case for health plans, is what I just briefly summarized. The next is a health plans guide on multiple ways of paying CBOs for social care services. The third document focuses on operationalizing contracts, and another document will focus on how to develop the scope of work for contracts. So next slide, please. This is are some links to existing partnership resources, and these will be available to you through the playbook follow-up materials, as well as I think you're going to start seeing some things in the chat here as well. And Marisa, I think the next slide is yours.
Yes, it is, please. Next slide. And we also wanted to share some additional resources from the Aging and Disability Business Institute, our contracting toolkit which was shared in the chat, as well as we have success stories in our partnerships in action. We maintain an evidence bank, which provides research studies related to services that CBOs provide and the healthcare outcomes that they're able to achieve. And then finally, we have readiness and assessment tools, as I mentioned earlier, both for community-based organizations as well as for networks of community-based organizations to gauge their readiness for healthcare contracting. And with that, I will turn things over to our next set of panelists.
Great. Thank you, Marisa and Lark, and really thank you all for the opportunity to be here. I'm Shantanu Agarwal. I'm the Chief Health Officer for Elevance Health, and if you don't recognize the name, you may know us as Anthem or Amerigroup. Elevance Health is the parent company. I'm an ER doc by training, and joining me as well, you'll get to hear more from her, is Susan Rawlings Molina, who is CEO of a really important strategic partner of ours named Ground Game Health. So I think the tee up for this section has really been wonderful. Next slide, please. What I'll say is from an Elevance Health standpoint, really addressing members' whole health needs is very critical. Whole health is actually more than just a call. It goes beyond just a phrase for us. It's actually central to our business strategy. We do believe that by addressing whole health, we can drive healthcare affordability and value for the entire system. And so it's a central plank of our corporate strategy. This is what whole health means to us. As you can see, health equity is truly at the center of our whole health approach. That is, we feel it is extremely important to give every person a just and equal opportunity to optimize their health through a multitude of different interventions. Whole health also means bringing together what is traditional, often physical care delivery, the kind of care delivery I was educated on in emergency medicine training, but also bringing that together with behavioral health care and delivery, as well as addressing social needs. All of these three components, I think, are very critical to make sure that we are truly addressing the whole health picture of a member and getting all of their different needs met. And the last thing I'll say just on this slide is that we are also trying to bring this approach, of course, to our members, which I'm going to talk most about, and that's what you hear a lot of what Susan describes. But we are also, frankly, bringing it to our own associates. Oftentimes we will conduct a demonstration, in addressing social needs, for example, with our own associate populations. We've created, for example, food programs for them. We've created a separate social needs program for them where they can call in to discuss their needs. We will screen them and get them connected to the most appropriate resource, whether it's inside Elevance Health or in a community. And finally, we're also bringing the same approach to our foundation as it provides community level funding and different grants. In each of those grants, we have baked in addressing social needs as central to that grant. Next slide, please. So our social needs program, we call community connected care. And that is really, again, just to emphasize that there's connectedness is a critical element of this solution, connecting the different elements of whole health to social, but also connecting us and our members to communities. These are the three major elements of community connected care. So first is making sure that we leverage data and analytics to better understand our members' social needs. We obviously have a lot of data from literally decades of being in the benefit space. We get claims data, EHR data, other kinds of data. We want to make sure that we're using all that to uncover social needs wherever we can. The gold standard is, of course, getting in front of a member and asking them what their social needs are, using validated tools and making sure that we're engaging them in the right way, in a very empathetic way. But oftentimes we can get a head start with the data that we have or are able to bring on board from other sources. That can then help us prioritize which members are likely to have social needs. And then, of course, that engagement with the member is really critical to make sure that we are hearing directly from them what their needs are and how we can get those needs met. And then finally, bringing solutions to bear. The conversation today is, of course, really about community-based organizations and the partnerships between organizations like ours, like Ground Game Health, with community-based organizations is extremely critical. But when we think about solutions, it also needs to include our own benefit design. So quite often we are able to point a member back to a benefit that they already have that they may not know about through Elevance Health. Of course, it can involve connecting them to the community or broader social safety net. So we really want to be very comprehensive in the way that we think about solutions that we can bring to bear for any given member. Next slide, please. And actually, I think Diana made a really critical point up front, which I will just emphasize again. We have been investing in this space for a number of years now, and frankly, other stakeholders and the regulatory environment have caught up and in many ways will be further pushing us particularly into addressing social needs. So I thought it would be valuable for all of you to kind of hear what those pushes are across the different lines of business that we have. So we are, we have over 47 million members at this point in Elevance Health that cut across all of the major lines of business: Medicaid, Medicare, the individual marketplace or the exchanges, and finally, employer-sponsored insurance. And in each of them, actually, there are new requirements coming online that really incentivize and require addressing and assessing social needs. A cross-cutting one that I think is important for you all to be aware of are quality measures. So there are brand new quality measures in the HEDIS program. The HEDIS program cuts across really all of the lines of business, all of the different membership types. Those measures now require us to assess the social needs of members and get them addressed in three major areas: food, housing, and transportation. So you will see certainly a focus among Elevance Health and our peers in those three areas. That also means getting data reported to us that can be reported back to oversight organizations that meet those quality measurement requirements. So that will be really critical. In Medicaid, of course, addressing social needs has been it's very commonly part of requests for proposal. That is what health plans write to in order to meet the bar in getting into a state Medicaid program. In Medicare, CMS is baking addressing equity and social needs into the STARS program, which is an extremely powerful lever over how Medicare Advantage organizations act and react. And then various exchange programs as well are really pushing into addressing social needs and health equity writ large. So there really are, I do think there's this confluence of forces now aligning behind this area. I think that's positive. I think it's ultimately very beneficial for members and very critical to addressing their needs. And so it also, frankly, builds on a foundation that we have been working to develop with our critical partner, Ground Game Health. So let me actually turn it over to Susan to talk about that partnership.
Thank you, Shantanu, and good afternoon, good morning, everybody. Can you move a couple of slides for me to what looks a bit like an hourglass? One more, that one, thank you. So great to be with all of you guys, and great to hear from our fellow panelists here. Many things are happening, and Shantanu, I couldn't agree more. Kind of a confluence of activity happening on the ground, happening with regulators and government. Maybe a long time coming and understand and just broad understanding of how critical at a human level addressing social needs and connecting those people to their clinical needs, maybe PCPs, or just getting their very basic human needs met is top of mind for all of us. I'm going to spend 1 minute on ground game, and I wanted to highlight maybe 4 or 5 things that I think are important in terms of how Shantanu and I and our teams over the years now have been able to make headway, right, and carving some space in this very new ground. What ground game has a CBO DNA. We were founded in Indiana in 2017, and with Aging and In-Home Services, another very large and great AAA in Northeast Indiana. Working kind of on the ground very pragmatically to address, gosh, how do I help these people stay out of the emergency room? It was folks who the medical director in Indiana really deeply understood that he just wasn't able to address social needs in the clinical framework, and engaged our original founders and created what's now become Ground Game Health. As Lark mentioned, we do contract in Ohio, and they're one of our very early participants, and we've been very successful there, actually working in the commercial business, among other lines of business. And many of the things Lark mentioned, I think are really important. And one being the local presence, and the one being thinking through and really pragmatically dealing with how do you operationalize these type of arrangements. And I joked around when we were doing some of our prep. I've asked my team a million times to give me an hourglass slide. This is as close as we could get. And I envision our work at Ground Game Health as an organization who operates in the middle of the people, if you will, at the top of that funnel, who are working to find a way to work with community. And those folks that work in community on the ground, which is at the bottom part of that funnel. If it were opened up, you could imagine maybe an hourglass. And we function very, very much like an MSO in this space, because what we've learned over the last 5 years or so is that it's a lot, there's a lot of things that go on in making the work happen that requires some help and guidance and participation by all parties. And you know, we've talked about some contracting, a lot of the great work that US Aging and the partnership is doing around contracting and aligning the organizations broadly around the country, which is excellent. And it's great to hear. I want to highlight a few things for you guys that I think go beyond contracting maybe, or maybe strengthen how you may want to consider thinking about contracting. That we've learned as I say, bushwhacked new pathways here. The first one is around relationship management. And obviously Shantanu, who's an executive at Elevance, and me, who's an executive at GGH, we work together very, very closely with our teams, deeply engaged across both of our organizations. Obviously, Elevance is a much larger organization than GGH. But I think a very substantial learning we have that I would like to share around that is and I think one of you guys may have mentioned it earlier, it's very much like a translation service, right? We have a group of organizations that want to influence and work with community, and community organizations that are experienced working in community that have different business models. And the ability to align those business models for the service of the human at the, on the ground is a lot of relationship management. It's a lot of alignment in goals and a lot of alignment in expectation, and trying to define those early on. So as the work begins to happen and the work gets executed, where things go awry become very clear early on. And it may seem like a really obvious comment, but I will tell you, my team and I, and Shantanu's team and his other parts of his organization, we spend a lot of time talking to each other about how to make things work. The business models are so different, and the requirements on both organizations in the arrangement are very different, that we found our role in the middle is very value added, in that we can kind of help bridge those understandings and bring the experience of both some of our history on the corporate side, let's call it, and our DNA in the community side together to make arrangements work. But relationship management is critical. And I think out of that, we've learned to respect the complexity of all the organizations, and that we have to find a way to try to not do too much too soon and get some real strong execution on the ground, and learn from that, and then evolve it, and then evolve it again, and evolve it again. There's so much conversation about it. There's so much desire to partner that I think how we structure our relationships are very important, and how we staff for those relationships. Underneath that overall relationship management, there are a couple things I'll highlight. One is how you contract, and thinking about those contracts around, gosh, are you a vendor or are you a provider? Are you going to take any kind of risk, or are you going to bill some sort of fee-for-service type of a contract? Are you partnering in a provider situation where you're working with a hospital, for example, who might be under a different financial structure? The concepts underneath the contracting, although community is very experienced in contracting, they typically don't contract the same way managed care organizations or providers might. So it's a thing that we've learned and have had to continue to evolve as we've worked through our relationship. It's a very important and binding process that can build success or stoke a fire that is hard to put out. Operational management is one I would highlight. Again, you have organizations, and speaking with our partnership with Elevance, for example, many times we talk about our operating volumes. How much are we pushing through? What type of work are we going to do? Which specific cohorts do we want to focus on? And at the same time, working with our partner communities who are delivering this work on behalf of the members and on behalf of GGH. We contract with partner organizations downstream. How do you manage that operating kind of fluctuation? We at GGH work somewhat like a modulator, and we have great partner organizations who work with us on the ground to help manage that volume. Business model, once again, is very different. You ask, I might ask Shantanu for a promise. Elevance and other MCOs typically can't provide promises, and community organizations don't have extra resources typically to just sit and wait for something to happen. So how we balance that in the middle is something I think is worthy of conversation and consideration as many of you get into this space and become successful. A fourth thing I'd like to highlight is around compliance management. Once again, community has a compliance structure it follows, and those providers, managed care organizations, Elevance also have compliance requirements, and they're sometimes similar and sometimes very different. One of the things that Shantanu mentioned as he listed out his lines of business, Medicaid, obviously folks who are on Medicaid and ACA in some cases are typically very needy, or needier, let's call it, relatively speaking. But boy, those Medicaid requirements change state by state, right? And they're narrow enough in some cases they look the same, but they're really not. And there are political considerations state by state, as many of you know, that thinking about how you comply with those regulations and enable the MCO to have you, for example, and have the services they need provided in a benefit structure becomes really important. And it's something that's not naturally aligned, at least at least now as we're kind of bushwhacking new pathways. Second to last is having some technology capability to track and manage all this. So when you're doing your contract, you may decide, gosh, I'm going to act as a provider and I'm going to bill as a claim. There are certain things that are required to bill as a claim, as many of you know. And so you have to have some sort of capability. In our case, we have our own proprietary technology called Amplify, which stands for Impact Amplified. And that particular technology enables us to track basically everything and protect data, but do it in a way that we can bill either as a vendor or as a claim and meet requirements. So there are things, and of course, track data and track what's happening with the member and things like that allow you to manage workflow and allow you to manage your business in the context of this contract more effectively. But it doesn't have to be technology, but given the tremendous amount of compliance that's required and all the activity going on, if you have a platform type solution like ours, it allows the work to be done more effectively, more efficiently. And the final comment I'll make, and I'll try to wrap it up here, is a key factor is how do you measure success? I ask this question all the time. What problem are you trying to solve? In this particular, let's call it field, there are so many different problems that people present with, and each of us are different and unique human beings that have a particular set of issues that may need to be handled differently. And if we're as collectively and individually, if we're not careful, we end up solving a series of problems that may be exactly what has to happen for that member, but might not be the actual problem that needs to be solved to deliver what the managed care organization or provider, for example, might be looking for, the state. So defining the problems and the measurement criteria as early and often as possible and testing it would be a thing that I think we've learned that we have to do continually better and better all the time. And with that, I think I'll stop and turn it back over to the moderator. So we've got plenty of time for questions, and thank you.
Thank you, Susan. So we're going to ask all the panelists to come back on screen, take down the slides. Thank you for that wonderful overview. And I think, first of all, I want to note that there were a number of questions in the chat talking about, what do we mean by community-based organization? What do we mean by community care hub? So first of all, want to level set there because I think a lot of this work often is trying to speak the same language. What do we mean by CBO and community care hub? And I'm wondering if I can turn it to at least one of you, maybe Marisa, if you could provide an overview of what you mean when you say CBO or community care hub, and perhaps highlight some of the efforts of the partnership to align social care to create a glossary and in addition to other resources.
Sure, I'm happy to kick that off. And then I might also turn to Lark to talk a little bit more, since she has been actually heading up the working group on CBO contracting and certainly has been involved on network development, as we heard before, in Ohio. So when we talk about community-based organizations, first of all, just to define the acronym, CBO equals community-based organization. When we refer to community-based organizations, we're talking about organizations like area agencies on aging, like centers for independent living, like housing providers, or transportation providers, other organizations that are providing social services at the community level. When it comes to community care hubs are the organizations that are at the center of networks of community-based organizations. They are basically the administrative and organizing backbone of networks of CBOs. And networks of CBOs could cover a city, could cover a county, could cover a region with a state, could cover an entire state. In some areas, we are even seeing networks that cover multiple states. And you certainly heard from Susan about that in terms of the great work that Ground Game Health has been doing over the past several years. So Lark, I don't know if you want to add on there in terms of a more formal definition of a community care hub.
Well, I think Autumn is throwing up here the formal definition that the partnership developed for a community care hub. But Marisa has described it perfectly well. A single community-based organization often has a single focus. It doesn't always, but it often has a single focus. And the community care hubs act as one contracting entity that can provide a whole network of services from individual community-based organizations. So it's a great concept. The partnership has done a lot of work. They actually have done a webinar. I think it's among the resources, and they have what a fully functioning community care hub would look like, all the pieces and parts that are needed for that. So there are a lot of great resources out there, but I don't have much to add to what you said, Marisa.
That's wonderful. Thank you so much for that level setting. I think it's always important, even if you've been in, talking this language for a long time, to circle back and say, well, what do we mean by CBO? Because, for example, federally qualified health centers sometimes refer to themselves as CBO. So for this discussion, I think we're focusing in on those health-related social needs and the organizations that provide services that address health-related social needs. Often in my world, it's folks that deal with home-delivered meals or asthma remediation providers. There's a lot of different types of organizations that can provide those sorts of services. And so even within those sectors, within that social care industry, there's a whole diversity of different organizations and different services that you may be talking about here. And I think one theme that arose was, these partnerships are new and these partnerships are different, right? It's not just developing a relationship with a new primary care provider down the block. It's going to be fundamentally different, and there may be different needs for these partnerships. And I'm wondering if the folks on the line can perhaps talk a little bit about how they approach these partnerships differently, and what was perhaps like a aha moment that came to them when entering into this work. And perhaps I can start with Shantanu here.
Sure, thank you for that. So I totally agree. We are kind of still in early days around these partnerships, and frankly, as a few of us pointed out, the ecosystem is changing around us. I think what guides us is first, when we are a national health plan in our scale, and so we have to be, I think, somewhat pragmatic about how many partnerships we can get into directly with CBOs through our local plan footprint versus working with partners like Ground Game Health that can obviously create large networks, almost act like their own hub in any given community, working with a wide variety of CBOs with a wide variety of skills and capabilities that can then meet the needs of our members. So there is sort of always this question of, do we go direct to the CBO or not? I think partly what now influences my thinking is because there's more regulation and oversight in this area, we want to be really thoughtful about what requirements we place on top of CBOs. Again, CBOs represent a huge diversity of organization types with many, many different assets and capabilities. Some of them are quite small with relatively few assets. We need to be really careful before essentially requiring them to report data to us in a HIPAA compliant manner, or report data to us in a way that might meet quality measurement needs and standards. Those standards are very appropriate to apply to us. We've, had to deal with those standards for a long time, for decades. Transferring them or kind of devolving them to the CBO can be a real challenge for the CBO. So I think there's a wide variety of factors like that say, okay, this CBO is large enough, capable enough, we can directly contract with them. Perhaps these others are not. It would actually be kind of crushing to them to have to deal with our oversight requirements. So let's work through a ground game health, for example, in order to make it easier for them. I think this will play out over time. And as solutions mature and the requirements mature, the models around this, we'll probably start to see 2 or 3 successful models that we can all adopt.
That's great. And often, and there were a couple of questions in the chat, like, is this available in California? Is this available in Louisiana? I will say that every state context, especially when you comes to Medicaid, every state Medicaid program is a little bit different, but there is a consistent thread, as you noted, the interest in health-related social needs, interest in health equity. And so those partnerships might look a little different in every context, but it will, there would definitely be opportunities, I think, no matter the state context. And I'm wondering, thinking about, for example, California, thinking about other states that have done this work, sometimes the question is, what does the workflow look like, and how do we get reimbursement for these services? And I'm wondering, Susan, if you can talk a little bit about how you sort of negotiated those workflows, keeping in mind that perhaps, each MCO might be a little bit different in terms of what they want or need, and how you make that workable for the CBOs that are working with ground game health.
I'll do my best. I think it depends. There's a lot of in our relationship with Elevance. It's pretty streamlined. Okay. And without giving away overly specific detail, essentially what we do is we hold the contract with Elevance. Elevance in this situation identifies those folks who they believe might need help, and they electronically send those to us. We send them to organizations like LARCS via our technology. And then the locally based organizations do social assessments, identify needs with the member, get those needs fulfilled. And then we, on the technology, those services, when the requirements are met for those services, they're billed to Elevance as a claim. And then Elevance pays us, and we pay via our contracts, pay the CBOs. So the CBOs are paid to do that work. We don't keep the work. With minimal exception, there are times where we don't have a partner in a place where Elevance, in this particular case, might need some support. And so we'll staff our own care coordinators. But generally speaking, our preference is to work directly with community on the ground locally.
And I saw a number of questions, both perhaps in the chat today and then also upon registration. Folks are wondering, what, to Susan's point earlier, what are you trying to achieve? What sort of outcome measures are you thinking about in the context of these partnerships? And how have you modified that to think not only of the health plan context, but also, sort of centering the member's experience of care?
Is that to me, Diana?
Yeah, you can start if you'd like.
Sure. I didn't know. I think it depends on the relationship with your partner, right? So in the Elevance case, we have a variety of different opportunities to support their members through their product lines, as Shantanu mentioned. And it depends on what problem we're solving. Okay, so if there may be a particular group we did, and I don't know, Shantanu, how much detail I can safely say, but we did, for example, a vaccination program in California for them. And the measurement was how many folks we got to check the box on vaccination, where there may be another situation, for example, the way we started, where we had folks who are very active emergency room utilizers, and it was because of socially driven issues. And so we actually measured those individuals and their usage of emergency rooms after our intervention. And I will mention some things like that typically are not a one-time intervention. Food insecurity is not a one-time intervention. So program structure, kind of my point, the point I was referring to at the end is, how do you measure success? It really does depend on the relationship and the problem you're solving in that moment. Hope that's helpful.
I totally agree with Susan, and just to add to it, I do think we're still learning, and probably, you know, our peers are still learning what the impact of addressing social needs truly is. I strongly feel that the impacts are pretty diverse. You can get things like improved vaccination, I think, by addressing social needs and barriers. I think ultimately we could affect quality of care that people are getting by giving them better access to care, by making sure social barriers don't get in the way of kind of getting traditional healthcare services. I think ultimately we could show that the cost of care is changed, because often by addressing social needs, you are addressing the root problem, not the downstream problem, right? So could we get people to use medications less or perhaps not at all for a particular condition because we've addressed the social need that was underlying that condition? I can't pull on every one of those threads from a data standpoint today, but we are very interested in exploring all of that. I think that's the promise that social holds. And, you know, a lot of what the data is that has come to light over the last several years that, you know, has gotten the government and regulators and others to really focus on this area.
Lark or Marisa, would you like to comment?
Just that I agree with everything he's saying. And we've also seen really good outcomes when it comes to individuals who are discharging from the hospital and getting in quickly with this, and not just nutrition. Of course, nutrition is a vital service, but being able to link them to all the services that are in a community. We really see a reduction in any kind of rehospitalization and ER visits that, you know, follow up. So that's been a very successful time, I think, for those social care organizations to jump in and really help out.
And I'll just add one quick thing, because I think, you know, Susan and Shantanu and Lark have provided great information about the kinds of health and quality of life outcomes that these CBO healthcare partnerships are able to achieve. But when we talk with community-based organizations about how they take some of that data and present and factor it into a value proposition that they can present to potential healthcare partners, we also emphasize really what we call sort of you know, soft ROI, the kinds of high touch, very personal services that community-based organizations offer on a daily basis in people's homes can really add to in particular, a health plan's ability to retain members. So I just wanted to throw that in there as another sort of arrow in the quiver, so to speak, in terms of the kinds of results that community-based organizations are able to achieve in partnership with healthcare organizations.
And those are some of the things that in your value case document that's coming out very soon. There may be a link already in the chat, but that's exactly what they address, all of those different ROIs.
Well, thank you so much for your amazing presentations today. I really appreciate your time. I hope everyone has walked away thinking about how community-based organizations are important for building trust, important for improving access and quality of care. I also hope that you understand that this is a work in progress. There's going to be a lot of learnings in the future. And resources like the bettercareplaybook.org can help you elevate some of those potential learnings and resources for you. When we end this webinar, we will have a evaluation survey that pops up. We really want to hear from you and see what you liked about this webinar and where we can potentially meet your needs further in developing resources. So thank you. What a lovely group today. And I hope you have a great rest of your day.